I want to thank you first and foremost for coming out, and welcome to our, I keep saying new space. We've been here a year, but I would still say it feels pretty new, looks pretty new. So thank you for coming to Kaplan. This is our second exploreID event for the semester, and the point of these events really are to bring, is it too loud? Okay. One moment. Is that better? A little better? Okay. Okay. Speak up at any point if you can't hear any of us. We can change that really easily. So thank you for coming. exploreID events really are, meant to showcase the vast amount of work that we're doing here at the Institute of Design, both for prospective students, what might you do while you study here, but also for the design community in Chicago and beyond to just learn a little bit more about what our faculty and students and community partners are up to. Tonight we've got a really awesome talking about some work that IIT students and faculty, Tomoko and Prachi behind me, among many other students, have been working on with University of Chicago Medicine. And we've got a panel of users, of those who were there from the beginning, kind of creating this thing. So I think we'll have some really valuable perspectives here. And with that, I'm going to pass it off to Prachi, who is moderating for tonight.
Thank you. So I was warned that there is some frequency change, and which is why this will cut out. So just for two, that's kind of the hope, that I get to know that you can't hear me. And so I'm going to hand off the mic so that the panel can introduce themselves. But at first, I'm a student at the Institute of Design. I'm a second-year student, but I did foundation because I don't have a background in design. And so this project was really special. The one that is going to be talked about was done in phase one before me, and then a team in the next year, I worked on another project similar to this. And it was really special because I, from a background in psychology and anthropology, could never have imagined being able to contribute to something like this, which was visual. But there are many, many techniques and many, many things that we all bring to the table at the Institute of Design for something like this. So if after this panel, if you just want to talk to a student who's here, I'm happy to chat as well. And with that, I really would want to let the panel introduce themselves.
Hello, can you hear me? Okay, it's on. My name is Tomoko Ichikawa. I'm a clinical professor here at the Institute. My background has been in communication, so taking complex information in different fields and making them understandable and accessible for the context that it's going to be used in. And so while, I can't remember how many years. And I also teach the foundation class, bringing in students who don't have a design background. I myself did not have a design background before coming to the Institute of Design, so I can empathize with them as well. But it's been a privilege to work with Dr. Golden and the team on this project. Dr. Dan,
I guess I'll go next. My name is Dan Golden. I'm an assistant professor of radiation and cellular oncology down the street at University of Chicago. I am an MD and I have a master's in health professions education, which I completed about 2 years ago, which focuses mostly on educating health professions students and trainees, but I've realized in the last few years it also applies directly to educating the patients. And my academic interest when I'm not seeing patients is medical education. As I said, I've realized in the last few years that can cross from not just educating our trainees, medical students and residents, but also helping to educate patients using best practices. And this was really amazing collaboration that developed along with the help of Brian Callender, talk in a minute. And I have 3 kids, 2 guinea pigs and a dog, and a wife who are wonderful. Also my chief collaborators.
My name is Jeremy Overcash. I'm a student here at IIT. This past summer, I was diagnosed with Hodgkin's lymphoma. I had a very rare form of the lymphoma, in which I don't receive chemo, and I only receive radiation. And so I'm a patient of Dr. Golden's, Dr. Dan's. And so, yeah. Oh, yeah. I actually brought it with me. Dr. Dan gave me this, the pamphlet that we're going to be talking about to help me more or less cope with what I'm going to be going through and understand everything that comes with it.
Sort of? Oh, there we go. Okay. Okay, so yes, my name is Brian Callender. I am a physician down at the University of Chicago, and I primarily take care of adults who are hospitalized. I'm something called a hospitalist. My non-sort of clinical interests or my academic interests are the health humanities, and within the health humanities, particularly the field of graphic medicine, which we'll be talking a little bit, but which is essentially the intersection of comics and healthcare. And so that's sort of partly where this idea came from, is in terms of thinking about what are the stories of patients and how can we incorporate those into patient education.
Yeah. Thank you, because that really is the question I want us to start off with, just the project's inception. I think we all really want to understand, like, what was the problem, and why did you guys think that design would be a relevant approach? Whoever wants to start with that.
I can, yeah. Well, I'll kind of start from my beginning. I should recognize, so there's the Bucksbaum Institute for Clinical Excellence at the University of Chicago, and I don't know their mission off the top of my head, but essentially it's to foster research and interest in patient-physician communication and the patient-physician relationship. And I attended a symposium that they put on, at which Brian presented a project he'd worked on with here at ID, developing a graphic narrative explanation of the inpatient team at a hospital. So when a patient gets admitted, who are all the players that they're going to see, doctors, nurses, respiratory therapists. You could explain it better. But I saw that and said I'd already been thinking about using graphic narrative to explain the radiation treatment process. So I talked to Brian, who put me in touch with IIT, and I got in touch with Tomoko, and that was how we developed the collaboration. As far as the problem that I had seen in my own clinical practice was the way that we explained radiation to patients traditionally was through verbal discussion. Sometimes I'd have a blank piece of paper and I'd draw on it a little bit, but there were no visual cues. Oftentimes patients would just nod their head and say, but I never really knew if they actually understood what I was trying to describe to them. And I had seen graphic narrative being used in other contexts and felt maybe that would be a valuable way to supplement what I was trying to explain verbally. And so when I saw Brian's presentation, it was kind of an aha moment. I don't know if you want to explain where you got the idea, the airplane.
Like I said, well, okay. Even if I just talk loud, is that going to be okay? So I kind of more humanistic side of medicine, kind of coming from the health humanities, and really thinking about what is the experience of the patient that's ill, right? And in particular, the hospitalist, I was concerned with the problem of what is the experience of while they're hospitalized, right? It's a particular traumatic experience that occur when a patient is hospitalized, and we do a really bad job education in educating them about what that experience may be like, right? And so around the time that I was sort of thinking about this, I became interested in just the illness experience as relates to a patient, and thinking about, well, how that unfolds as a narrative, right? And so I started thinking about, well, how does that unfold as a narrative in the hospital, and are there ways to generalize that enough so patients can better understand what their experience may be like in the hospital? And so using it sort of a more narrative format that you can lay out what's going to happen in admission. Give a general sense of what may happen during the daytime. Things change at nighttime, so give them a sense of what happens at nighttime and give them a sense, too, of what happens at discharge and what to be prepared for. So patients aren't really living like a day-to-day moment in that hospital experience, but they have a sense of what to expect. And like Dan said, one of the common problem in the hospital is like recognizing your general team. What are their responsibilities? And so one of the other additional aspects of this was to provide patients with a general sense of who is on their team and what their roles are, but to do it in a graphic form. And we felt that by putting on a graphic narrative, more images, that patients will then sort of, one, be visually attracted to that patient education pamphlet, but two, that it sense of what their narrative looks like and what to expect. I think one of the problems with patient education in general, I mean, if any of you have received patient education pamphlets, they tend to be really wordy, and they just tend to be a lot of like bullet points and information that doesn't really contextualize how to use that information in the context of your like illness experience. And so the goal of some of these contextualize the illness experience within patient education materials, so patients can actually sort of immerse themselves or sort of insert themselves within those materials. And so that's sort of one of the main ideas about thinking about why sort of using graphic narrative in patient education materials.
And actually, to just talk about in relation to radiotherapy, what Brian was saying is I'd done a study with a medical student a few years ago where we took all the available patient educational materials from 3 of the largest radiation societies, well, including American Cancer Society, and did something called a readability analysis. So we looked at the text in those and what grade level they were classified at, and the average was around 11th grade. In the United States, the average reading level, recommended reading level for patient education materials is 6th grade. This has to do with length of words, so syllables per word and words per sentence. So our patient education materials, which are often written by physicians or other health professionals with high education levels, have very long sentences with big words and aren't easily understood by patients. So what I was looking for is a way to improve the education of my patients, not only through lowering readability levels, but also using other forms of communication. One other quick side note, does anybody here know where the word doctor comes from? Anybody? So it comes from Latin docere, which means to teach. And I view my job, and I think a lot of my colleagues, Brian as well, view their job as not just providing medicine, but also teaching and educating their patients about what they're going to experience and how they can improve their health by understanding their disease process better. So that's a big part of what we do, and having better tools to do that is really important. So,
I think design be agnostic about the situation. We are not the patient. We are not the doctors, but we are around users to find out what their needs are and where their pain points are, what troubles them, what frightens them, what they're confused by. And so applying a design research process to uncover these things and then being able to apply it to a solution made this a very appropriate type of project for us to engage in.
Yeah, and I also wanted to just welcome everybody. If you feel like you have a question now, we don't really want to do a Q&A completely at the end, so feel free to raise your hands for questions. We're happy to take them. We really do want this to be interactive because we do have a panel that really is someone who's deeply engaged in this space, so let's use as much as we can of their time.
I'll bring up one other,
Sure.
just about the problem, identifying the problem. Just by a show of hands, how many people, so a little bit of background, when I see patients, I tell them there's 3 ways we can treat any cancer or malignancy. We can do surgery, chemotherapy, or radiotherapy. So by a show of hands, how many people here know someone who's had surgery? Pretty much everybody. How many people here know someone who's received or taken a drug for any sort of medical problem, which is essentially what chemotherapy is? How many people know someone who's had radiotherapy? So some, how many, well, I won't ask how many have had radiotherapy, but oftentimes people don't, they understand drug, they understand surgery, they don't understand or haven't had any experience with radiotherapy, at least not close and personal. Maybe they heard about somebody who had it, they had bad side effects or something scary. So that was the other problem that, I identified.
Yeah. And I think it might also be, we started the conversation on like graphic narrative, but it might also help us in the room who maybe don't have as much of a sense of like the history of it and what really is a graphic narrative. If we could just even understand that to sort of, could you tell us a little bit more about that?
Sure. So for the last couple, like I said, I've been sort of dealing in graphic medicine, and graphic medicine, sort of the simple equation for graphic medicine is comics plus medicine equals graphic medicine. A slightly more formal definition is the intersection of comics and healthcare. And so this field has existed as a more formal field 15 years or so. This last year was like the 10th annual conference, and so there is an annual conference that comes with graphic medicine. It's a wide range of people who are sort of interested in this, from cartoonists, from physicians, from other providers, from librarians, to art therapists as well. But just in terms of going further back, that there were comics that were related to medicine going back into the 50s and 60s, and even beyond that, there are cartoons and short comics related with medicine. But it wasn't really until about 20 years ago or so when graphic novels were starting to be published or related to the sort of illness experience, whether by somebody who was suffering from some sort of ailment or a caregiver. And so these, what are called graphic pathographies are just essentially somebody's memoir about their illness expressed in sort of graphic novel form. And there's a whole host of them. I have a bunch of samples of here, but it's interesting to sort of think about some of the conditions that were some of the early memoirs. When I think of the genres, one is sort of cancer. So there's a large genre of graphic memoirs around cancer, right, and that experience. And then mental health as well, and there are a lot around depression and bipolar, and then some around sort of death and dying. But it's interesting to sort of think why some conditions, there are not that many about diabetes. There are a lot about cancer, a lot about mental health, and some of this, I think, comes from how do individuals who are experiencing going through an illness and engaging with the healthcare system, expressing what they're going through. And so what's interesting to me is to think about, well, why the medium of comics, and why might it work for illustrating this experience? And not to get sort of too philosophical about this, but some key components of the illness experience are lived spatiality, so like how space changes when one is ill, as well as sort of lived temporality, in the sense of how does time kind of change when you're suffering from an illness. I mean, when you think about what comics actually do, what a comic is, when you move from one panel to the next, that in that panel is space, right? Some sort of space. It could be a geographic space, it could be a clinical space, it could be space. And then when you move from the next panel, that's time happening, right? And so comics as a medium really allows an individual who is suffering from some ailment and going through the illness experience to manipulate and play around with space and time to better illustrate what they're going through. And if we think about medicine as sort of a field, there's a rich visual history of what medicine is, going back to sort of the anatomy texts, to sort of pathology slides, to radiographic images, to and now comics is sort of part of that rich visual history. But I think the comics as a medium is particularly interesting to think about expressing that illness experience. And when I think about the field of graphic medicine, there are kind of that come into play. One are these graphic pathographies. So just patients or caregivers who create memoirs about the patient experience, right? And the question as a physician is, well, what can I learn from these, right? How can I look at those as kind of a critique of what we do in medicine? And that's sort of how I look at the health humanities, right? That when they're critiquing the physician-patient relationship, what should we learn from that? when they're sort of critiquing other aspects of receiving health care, what should we learn from that? Then the other aspect, I think, important aspect of graphic medicine is patient education. So kind of what we're talking about. So how do we sort of harness and embrace what comics can do in terms of telling a narrative? And if you think about these pamphlets here, they tell the narrative of what's going to happen, right? In general terms, it's not going to be specific. That there are certain specifics that might differ from what's presented, but it allows you actually to create space and time. Like when you go through this, that spaces can be created, like the CT scanner, right? The clinic space, the hospital space can be created to give patients a sense of what to expect. And similarly, one of the things about these narratives and why comics as a medium works is it allows you to take complex processes and simplify them, which when you think about what radiation oncology is, there are multiple steps to it, and it's a complex process, but you're able to break it down into these sort of easily visualized steps. And so that's how I think, how do we use this in patient education? And then the last thing to sort of think about is how can we use comics and the creation of comics, not quite as art therapy, but to allow the patients in creating their own comics to come to terms with what they're doing. And so that I do in addition to patient education is sort of workshops working with patients, where we walk through a series of prompts to create comics, whether that's sort of talking about a clinical experience, whether that's doing a body mapping exercise, whether that's doing a life mapping exercise. But it allows patients to sort of contemplate and think about their illness and sort of lay it out in a way that that basically becomes their illness narrative. And then this also happens with sort of medical students and practitioners that create comics about what they're going through as well, and they're using that more and more in medical education spaces as well. There's a lot there, and I'll turn it over now.
Sorry, I'm going to change over to graphic narratives. Oh, that's better. Is the notion that it's not hyper-real like video, right? The idea is that photography and videography is very much real, and you are depicting somebody that's very specific, and the ability to see yourself in that is not very easy, whereas the kind of abstraction that we can see in these illustrations that we have, it could be anybody, right? You can see yourself a lot more easily in it as opposed to something that's much more specific and concrete as a visual medium. And so working with the students, they actually, when we went to do the interviews, brought several examples of the same situation done in 3 different levels of abstraction. One that was very detailed, another one that was somewhat detailed, and one that was very abstract. Kind of like the Goldilocks solution, right? The detailed one was too much information. The simplified one was too childish. So the middle one was just right. And the ability to then have people be able to see themselves in it became a very important part of the viewing experience of this discussion guide.
And Tomoko, speaking of that, I think that's a really good segue into kind of the process that like design brought to graphic narrative or graphic medicine in this case, in this particular application of it. There's a kind of 2 things that I would love to talk more about. One of them is like what were the constraints that we sort of discovered and were playing with, and then some of the priorities that we said that we would really want to follow through with.
So biggest constraint was that this was done in 14 weeks. It was a semester-long class. So time was a very big factor in what we did. Also, if you may know that when we deal with human subjects in research, we have to get what's called an IRB approval to go do the interviews, and we did not get that until week 5. So 14 minus 5, we technically had 9 weeks to actually go create go do the research and then create it. So time was a huge factor. I also think because for me this type of exploration was new, but I think having been a student at the Institute of Design and understanding that there is a rigorous process that you can go through, we sort of had to put faith in the process and did the work, do the research, analyze the research, synthesize what it meant. Some of these boards you'll see with things hanging from them are part of the analysis that we went through by figuring out what are the phases of this treatment journey, and then from the interviews trying to filter out, well, what could we show as illustration, so visualizing it into the graphic narrative format. What is the information that that patients need to know at each point in time in the phases? What are some resources that we are learning through our interviews that are applicable at the different phases in time? As you can see, each of these big blue rectangles on the left are a different step of the way. I think the slide after this one is going to show you, no, one more. The deconstruction of the interviews that we did. So this one, pulling insights out from the interviews and making individual cards out of them so that we could, as a group, as a team, work together rather than looking at an Excel spreadsheet on a laptop. So these were sort of methods that we had to invent to be able to do this as a collaborative effort. And then, the illustration team came in, the design strategy team came in, talked together, and said, this is kind of what needs to be translated into visual form. We also explored lots of different form factors. We landed on 11 by 17, a threefold panel. There was a constraint here as well. Dr. Dan wanted this to be accessible as possible, to be producible easily as possible from any kind of office printer, an 11 by 17 office printer that doctors and clinics might have. We did not want this to go to a professional printing office, because that would then limit the number of people who would have access to be able to produce this and use this in their clinics. So knowing those types of end result constraints helped us understand, well, maybe it could be 8.5 by 17 into a booklet, or maybe it's 11 by 17 folded into a booklet. Because of the way the information ended up being structured, the twofold 6-panel approach became the answer as we sort of made different prototypes over and over again, using very quick, rapid sketching of the sections and the illustrations that needed to be on there. And then you did some testing with your colleagues. You wanted to talk about that a little bit?
Yeah, so towards the end of the 14 weeks, we had a prototype, which I then sent around to, I think, about a dozen colleagues around the country and asked them to review it for applicability in their own clinic. Because one of the, as Tomoko alluded to, one of the design criteria I gave was that I wanted it to be generally applicable. I didn't want this to be specific to my institution. I wanted it to be something any clinic around the globe could print for low cost, reproduce for low cost, and use in their clinic. We can talk about some of the other customization I did, but I sent it out to about 12 or 15 colleagues and just had them review it, and there were some changes that came back because even though I had thought I knew what was done kind of generally, there were still specific things that were unique to my practice or my institution that it turned out didn't apply broadly, so we had to make some additional corrections there.
And one of the things that we learned through our research is that the notion of radiation therapy, people might say, oh, my aunt had that. I'll know what I'm going to go through. That wasn't really the case because everyone's journey is very specific and very unique. And so this panel right here, we wanted to pull out things that were customizable for the individual. So what kind of preparations they needed to do, what kind of, how many treatments they were going to get. Dan wanted to have a section where he could actually strike out, the last 10 sessions because perhaps this patient didn't need the full course. So being able to understand what aspects of each phase was a customizable portion became important to understand so that we could incorporate them into the My Information section. But I think learning about how to make things generalizable and not unique to any institution was another factor. So we used Avery labels. So you'll see that in the generic version, there is no mention of University of Chicago. Where a logo would go is blank, and it says use Avery sticker here. So we gave them a template where they could put their own institution's logos on. In the back, there's a section where there's relevant information about, oh, great. a live one. Thank you. Yeah, so this is blank, and then there's one with a sticker. And then in the back, there's a section that has specific telephone numbers for each institution. So patients can call, whether it's off hours or on the weekends, or for particular billing information. We created Avery label templates as well, so that anyone who knows how to use Microsoft Word can replace the phone numbers with their own phone numbers and print them out and stick them onto this. So making it very generic was another constraint or requirement for this solution.
Can I add one sort of additional challenge that I thought was interesting on some of sort of the pamphlets that I've worked on, and I think this one as well, is there are certain sort of criteria or sort of guidelines on what patient education material should contain, right? In terms of literacy levels, in terms of font size. Those conflict with what design principles would recommend. So, you may have something that from a design perspective looks great, and follows all those principles, but then you show it to somebody who does health literacy in your sort of medical institution. It's like, no, I would change this, and I would change this, and I would change this, which would completely sort of negate feature that you were going for. Font size in particular, when you're trying to do a narrative and you're trying to have sort of word bubbles, it's hard to fit and there are not even a lot number of words if the font size has to be like and so try to navigate and negotiate the expectations of the patient education folks with what the design folks are sort of recommending as well.
Yeah, we made a very conscious decision to throw out the font size because in a perfect world with unlimited resources, it'd be nice to have a large booklet with 20 pages and big pictures and big font, but we decided, again, for this to be widely disseminated and cheap to produce, to go with this 11 by 17 form. So yeah.
Yeah, and I think as a student coming in after this one had been done, what really appealed to me was that the design from like a patient education material that seems like a one-way to then making something that was a dialogue and that was a discussion document that was active and in use and was used at the moment of consultation. That was just exciting. And I think what's really cool about this panel is that we also have someone who you actually had this conversation with and used. So I would really love to know more about what was that two-way dialogue like and how really has this helped with that.
Let me jump in and then I'll turn over to Jeremy. But I also want to emphasize that one of the visions I had for this was specifically what you said. This was meant to be a discussion guide, not a passive pamphlet that was handed to the patient. So sometimes I've shown this to colleagues and they say, well, I already give out something from the National Cancer Institute or the American Society for Radiation. And I say, no, this is not meant to replace that. This is, in addition to that, to be used during your consultation as a tool to help guide and facilitate your discussion with your patients, which is different than traditional patient educational materials that are often handed in a folder and the patient kind of is expected by the doctor or nurse to read it later or while they're sitting waiting for somebody. This was, again, meant to be used actively during the discussion as a tool. With that in mind, I guess you can talk to Jeremy. So Jeremy, I don't know if you want to tell a little bit about when you came to see me and what was going on. Did you know anything about radiotherapy before treatment like that? But before you came to see me or were diagnosed, had you ever thought about or known anybody who had radiotherapy?
No, I had not. Sorry. I got my testing done at Northwestern Medical, and before I even got any of the testing done, my doctor had told me, hey, you have Hodgkin's lymphoma. You're probably going to need chemo. That's good because then you don't need radiation. So, of course, after testing, she said, good news, you don't need chemo. You only need radiation. And I'm like, only, I was really scared going into radiation, and I feel like this really helped me and calm me down. And
so I can give a little history. So up until the 1950s, there was really no curative treatment for any malignancy, and then certain types of chemotherapy were developed from actually mustard gases, that were used in the World Wars. Radiotherapy was also starting to, it was discovered in 1896 and started being used in Chicago, interestingly. Several months later, the same year, it was reported to be used to try to treat cancer in 1896. There were no IRBs back then, Tomoko. So, but it was in the 1950s that it started being used to treat Hodgkin lymphoma. And radiotherapy by itself was used. Patients with Hodgkin lymphoma would get treated to a very large volume of their body. So if they had lymphoma in their neck and armpit, they would get their entire armpit, both sides of their neck, the other armpit, and their entire upper chest treated with 5 to 6 weeks of daily radiation. And they were cured, and that was a miracle. Nobody had seen that before. But 30 years later, all these patients started coming into doctors with heart disease, lung disease, second cancers related to radiation, all these awful side effects, and there was a big push away from radiation. Chemotherapy had gotten better. We found we could use that to treat lymphomas, and so there's still this, I guess, fear around radiation because of the side effects related to the early treatments. But technology has changed a lot. We treat very differently now. We have better scans to localize the cancer, and so in Jeremy's case, I don't know if you want to tell where we had to treat.
Under my right arm and my
so
armpit
we
area.
literally were treating just right here. So his heart got no radiation, or virtually no radiation. So, the doctors are saying you're going to have, it's great you don't need radiation. Oh, wait, you do need radiation, and that's why they were kind of scared about radiation. But things have changed a lot now, and so having somebody understand why we're not as scared about using radiation in his case is important. So, I'd be curious, during the discussion, do you remember this guide being used? And he's not a plant, by the way. He's not being paid. We didn't know we were doing this until.
Wait, I'm not being paid?
There's free food. Oh yeah, he's very modest too. What's your major here?
Astrophysics?
Yeah. Anyway, do you remember the discussion we had after? So I did an exam. So at initial consultation, one other really brief thing I should mention is I realized radiation lends itself to this kind of graphic narrative because it has a very clear beginning, middle, and end. There's an initial consultation when you meet the patient, discuss the treatment. Then there's the middle, which is the planning scan and the actual treatments, which could be anywhere from 1 to 44 treatments, at least in my clinic. And then the end, I would say, is finishing treatment and going into follow-up. So at your initial consultation, when you first met me, after I'd done an exam and we talked, do you remember this discussion guide being used as part of the?
Of course,
and how was it used? I'm curious.
I remember it's foggy. It's been a couple months, but I do remember how you were saying before. If you were just telling the patient what they'd be going through, you'd be just going along with it.
You can pull the guide out. So I can kind of show you how I use it. So actually, I've been using it for almost 2 years in my clinic now, with every patient that I see, and it honestly is hard for me to imagine not using this before because it's become such an integral part of how I discuss the treatment process with my patients. But it's designed in kind of a clever way because I start with this My Information page, but there's a little doctor's sketch pad. And in Jeremy's case, because he had a somewhat unusual tumor, we have stickers with labels, Avery labels with anatomic diagrams, but I'll hold it this way. But in his case, I just did a very bad hand drawing of a stick figure and said, here's the tumor under your arm. But I also drew where his heart and lungs were and kind of showed him where the radiation would be hitting. And once we kind of agree why we're going to do the treatment, then it goes through the process. So step 1 is the consultation. We describe the treatment team. Then it opens up to step 2, which is the simulation scan where we plan out the radiation. Then step 3, and I go through this with all my patients now where we discuss how we do the treatment planning. And then step 4, which is treatment. There's specific things that came out from the design process. For example, patients that were interviewed said they were nervous. They didn't know if anybody could see them or hear them in the treatment room. So there's a frame right here that shows the patient on a video monitor. So all our therapists that do treatment can see the patient on a video monitor, and there's a 2-way intercom that they can talk to them. And so I always point that out. Every patient I see, I point to this one frame and say, we can't be in the room with you because of the radiation, but we can see you and talk to you, and you can talk to us. And then it describes the treatment. I always tell them you don't feel anything, it doesn't burn or hurt, you don't turn green, you don't glow in the dark. And if they chuckle, then I say you don't get superpowers. And then it kind of shows this cyclical, repetitive process with cars coming back and forth, trying to represent the repetitive nature, and then follow-up. And then it conveniently lands right back on this page where we then discuss their patient-specific treatment, I guess, specifics like what's the date of their treatment scan, what do they need to do to get prepared. We have phone numbers here to call directly to the nurse's station or the therapist if they need to change treatments. I always tell our patients it's a VIP phone number when we give it out to patients we like, but we give it to all our patients. But I find it an invaluable tool to explain the process in more than just a verbal manner, but also with a visual. I don't know. I would do it verbally, but I always felt like I was missing something, and at the end of this, actually, the final step of consultation is having the patient sign an informed consent form. So, anybody that's had a medical procedure or any sort of significant medical intervention has signed a legal form saying that they agree to have whatever's being done on them, and they absolve the institution of any and all liability, which probably not, it doesn't hold up in court, but that's what they want you to believe. Anyway, the idea of signing an informed consent form, in my mind, is that the patient is truly informed and understands what they're going to get or go through. And without this, I never felt like I was fully able to explain it. Even with this, it's, in a perfect world, I'd walk them through the machine and give them an hour-long tour and have them meet everybody. But this is maybe the next best thing. But it really provides a whole nother dimension to my discussion with the patients. They can point. I've had patients say, wait, I don't understand what's going on. And we'll go and say, well, here's where we make the mold that you lay in. So they can visualize. Like you said, they can put themselves into the graphic narrative and kind of see themselves in the process rather than just verbally hearing or watching a video or passively reading a high readability level handout later at night and not even anybody that they can ask about it. So,
if I can cut
Yeah,
in,
absolutely.
not only is the discussion invaluable, but being able to bring it home and keep it is too. Having easy access to it before not every treatment, but every milestone that I was hitting, I knew exactly what I was going to be going into, and it was depicted exactly as it happened. Of course, faces aren't the same, but it did really help me.
Did you use that as a way to explain your process, what you were going to go through to other family members or people who might have wanted to know?
Me and my mom both explained it to my dad. Dr. Dan explained it to me and my mom, so we kind of teamed up to tell everybody else. But we did use it to show people this is what I'm going to be doing next. And
that was one of the things that we did find out in research where patients were telling us that they wanted to be able to explain what they were going to go through but didn't have the means to do that. And so this was, in a way, a byproduct. So there's a side effect of this being able to support that kind of communication beyond the patient-doctor communication as well.
One of the things that came up in the initial design discussion was what could we do to make this valuable to the patient? And I think it was a colleague of yours suggested that anything a doctor writes on becomes like gold to the patient. And so I tend to write and draw a lot, or I already was, and we had patients bring in. I used to. Oh, you know what? I do remember now what I used to do. I would print out anatomic diagrams because I liked to draw on there, and I would write things down. But the process, the story of the radiation journey, was not something I could convey with my limited art skills, and in the 15 minutes I have to talk to somebody. But I did have anatomic diagrams, and we had some patients that were interviewed that actually had saved those and brought them back, and you took pictures of them and used them as kind of to see how the patients had saved them. But I think the fact that Jeremy brought this in again also speaks to, a lot of stuff goes in the circular file cabinet, it's a garbage can. But the patients, that a patient holds on to this and remembers receiving it and has it weeks into treatment or even after treatment, validates in my mind what that we accomplished on some level what we're trying to do. Is there a question? Yeah.
Hey, I'm Amanda Geppert. I work at UChicago too. I actually work with Dr. Gilliam. So I recently, we got a great tour of an exhibit that you curated at the Regenstein Library in utero, right? Cool stuff. Anyway, I want to ask a practical question as I'm preparing an NIH grant on a different thing. This is an amazing tool. And so I wonder, we've been prototyping some stuff over in PEDS and over in OBGYN. How has the creation of that tool affected the other members on your team from the care experience? So, I'm just looking at the photos, right, at the sketches, and there's different roles there. So I'm wondering, did the of this, it sounds like the moment of the discussion is very much with you, but I imagine that it also is supporting those other moments when you're not there, and do you have any kind of sense of feedback from your team or ways that practices might have changed in your clinic?
Yeah. So to give you more info about how we actually use it in clinic now, is the nurse that works with me will bring it in so when a patient arrives, they come in, and our medical assistant takes blood pressure, does some basic intake, checks medications, and then our nurse will go in and do about a 30-minute intake, going over the patient's history, going over some also basics of the treatment process. So she actually will use this as part of that. Then she leaves it with the patient and says, why don't you go over this? Dr. Golden will be in 10 or 15 minutes, because then she has to go and give me a report, and we discuss the case together, and then I go back in. So I often now will walk in the room, and the patient's kind of flipping through that, or they have it on their lap. Then I do the exam, and then I reference that again. So it kind of creates continuity through that aspect. Yeah. And we did interview nurses, the entire care team. One thing to mention is, I think you estimated that this was through the design class, probably 700 plus hours of effort were put into developing this. Which sometimes I feel like somebody in passing sees this 11 by 17 pamphlet and is like, oh yeah, that's nice, that's cute. I'm like, no, you don't understand this. There's a lot of effort that went into this 11 by 17 discussion guide. So, but there are these. But it has created that. The other thing that's hard to measure is patient comfort and with the rest of the treatment process. So we did a perceived benefit study. So we took this after it had been produced, and I gave it to about 15 patients who had already completed the treatment process and were in follow-up. And then I sent it to 30 patients, and I sent it to about 15 radiation oncologists around the country, and we gave them a survey that asked kind of their perception of how it would have changed anxiety levels and the usability of this as a tool in clinic. And it was rated as likely reducing anxiety and being very usable. So we actually submitted and were awarded a grant from our national society to develop 3 site-specific versions of this for breast cancer, lung cancer, and prostate cancer, which are the 3 most common types of malignancies in the United States and are treated with radiation treatment extensively. If that's the right word. Anyway, we use radiation a lot for those 3 types of cancers. So we're developing this further. Yeah, sorry.
Did you get any responses from that, and were there any further prototypes after that feedback? And what surprising things might you have learned from that?
So we didn't really test it on it. I mean, I guess in a sense we did. Generally, it was rated very favorably. We've had some comment. So because the class ended, our ability to make major changes was fairly limited because of resources and manpower or womanpower. Tomoko has kindly made some minor edits, little tweaks, but in general, we kind of stuck with what we had developed at the end of the class. I would say I've used it for 2 years, and I have pretty limited, if any, changes I would want to make, short of making major changes like potentially changing the whole form or redoing the entire process and seeing how we can improve it. One of the downsides to this is it was intentionally designed to be used for potentially any cancer treated with external radiation. So it is generic. There's space used to show different patient positions. So, for example, the lung cancer guide that we'll develop only has to show one position. These patients are all treated on their back with their arms up. But we may be able to include information about special scans that track breathing motion. For breast cancer, patients are treated on their back or their stomach, so we'll show only those two guides. There's also information about having masks made, which many patients, we treat their head or their neck, have a mask made. That can be very anxiety-provoking. Lung, breast, and prostate cancer don't get masks, so we can get rid of all of that and use the space for other more specific, site-specific information. So we are working forward. The other project we could talk about is COGB. You could talk about that, Prachi.
Yes, actually.
Oh.
Yeah, I was going to hand out the mic, but I was thinking about that when we did COGB, which was for a different
What does COGB stand for?
Yeah. Communicating the gynae-brachy experience.
Yes. No, just...
It's there in my head. It comes back. But that's for internal radiation, so it's a very different journey. But I think fairly quickly within the first few weeks, just talking to Dr. Dan and him sort of saying, hey, I start from the back where I sketch and then I go through the whole journey and then I do the customized information section, made us, when we were doing it, put the sort of space for sketching right up front. So the folding is different in ours. Ours is just 11 and a half, a tabloid paper folded in half, and it starts that way. So it looks like an 8.5 ply sheet. You have place to sketch. It opens up to show the full journey, and then it closes on itself where you write the sections. So the form is being evolved even with different applications of it. So iteration is just in a different space where we're kind of bringing it in.
We are planning to run I'm working to run a prospective study where we'll implement this across about 8 to 10 clinics around the country. Everybody will start not using it, and we'll collect anxiety surveys and some other data. And then it's called a step wedge design. So every 10 or so patients that get accrued, one site will start using this, and then another site and another site. So by the end of the study, every site is using it, and then we'll be able, it's kind of a funny way of doing a randomized trial where half the patients will get it and half the patients won't. But you have to do it this way, because once a doctor starts to use this, they may change how they counsel patients. Right? Somebody might say, oh my gosh, I never realized patients are anxious about being in the room alone, and they start telling them that. So you can't ask the doctor to not say that once they've used it. Although I've realized a challenge I'm going to have to figure out how to deal with is explaining how I use it, not just handing it to them and saying, here, use this, but really having them understand how to use it actively as part of their consultation. I may make a video of myself using it with a mock patient, because it might not seem like it to the patient, but I have a script that I'm kind of using in my head. I've been told by observers that the joke about superpowers seems very natural, but I have a scribe now that follows me and helps write my notes, and he's heard that joke with every single patient, and he's probably sick and tired of hearing it.
Does he transcribe it?
No. Yeah, patient will not receive any superpowers.
So I have a question. So you've been using this for 2 years. So did this group come in after you already had this, or I'm confused because 14 weeks, but you've been using it for 2 years.
So this project occurred in the fall of 2017.
Okay.
Yes.
And this was all created. This pamphlet was created from scratch for 14
Yes.
weeks.
Yes, and then after that, the 2 semesters after that, we actually spoke with a gynecological radiation oncologist who was a colleague of Dr. Dan's, and we decided that we would embark on another collaboration, and that resulted in what we thought was going to be one, but it turned out to be 3 different kinds of discussion guides, because there are 3 plus more types of gynecological brachytherapy treatment, internal radiation processes. But the doctor that we were working with, Dr. Hassan, chose the 3 top most used methods, and so we decided to create one for each of them.
So
It does? Okay.
is there could you just sort of the process that your group went through? Obviously you did some research.
Sure.
Can you just like do
Yeah, I can do that. So what we typically do is, we first use a couple of weeks to onboard so that we become, the students and myself become familiar with the process because we are not anywhere in that field yet. And then we decide what kind of questions we want to ask, so we create a research protocol. And through Dr. Dan's connections and folks that come to his clinic, we interviewed 8 patients. For this particular project, we interviewed 8 patients and 4 family members, 10 medical staff who were patient-facing, so other doctors, other radiation therapists, nurses. We also interviewed 2 medical staff who are not patient-facing. So in radiation oncology, there is a planning phase where physicists and dosimetrists, who are the people who craft the treatment protocol, understanding like what kind of dosage is required, for how long, they're in the background tirelessly working, while the patient doesn't know that, and they're asked to wait, and the patients become very impatient because why can't I start my treatment if you know what's wrong with me? Right? So in this, we also talk about the planning phase so that we can have them understand that this is a very highly customized treatment process. So that's why we had to also include them in the interview. We also interviewed 3 non-medical staff, patient support folks like social workers, and people who meet the patients at the front desk to sort of see what they gather in terms of the kind of anxieties or experiences that the patients go through. We audio record the interviews. We also have some activities in the interview that we ask our participants to engage with, and we sort of use Post-it notes to say who's in your care circle, who provides you the most communication. So we have an idea of who all the different participants in the treatment process is and their relationship to the patient, so that we understand like who's showing up when in the process, right? We distill the interviews down into specific observations or insights, which is what you're seeing on the boards there. We codify them, we cluster them to find sort of larger general patterns in the journey that patients go through. And then the designers do their magic and say, oh, okay, this is how we need to structure the information. There are going to be X number of sections. Each section is going to be so long, right? And we create a shell for the prototype. Many of them don't look like this in the beginning. And then we start to propagate the actual content to say, oh, this section needs to be a little bit longer, or we could do less with this section. And then we start to make it real. So that's kind of the general process that we take.
Yeah, so this was fall of 2017. I apologize if there's confusion. But it was an amazing experience for me because I went every Monday. So I have one day a week where I don't see patients, and I get to do academic things. I kind of do what I want. And so that's when I said my academic interest is education. It's this kind of stuff. And so I went every Monday to the class, and it was 3 hours, and it was amazing. There was a lot of work going on between those sessions, and so it was amazing to come in each week and see the interview protocol coming into shape, and then all the primary and secondary references that the students pulled about graphic narrative, graphic medicine, radiation. They combed the internet for different patient education handouts. I brought in samples from our clinic, and then then they came and started doing interviews in our clinic. I actually don't practice at the main university. My clinic's at a satellite or network cancer center near Joliet. So the patients, that was an experience, I think. Sorry, not the patients. The students had to get out there, but they took over one of our rooms and kind of made it an interview room. And then coming in and seeing these bulletin boards develop with masses of information being distilled into discrete kind of key snippets that then were used to drive the development. And you can see this example here is all these different insights that the students made through the interviews. I think as a physician, it was amazing because, like I said, this is 700 hours. I'm lucky if I have 7 minutes a week to myself. So to be able to kind of take my general design criteria, turn it over to a team that Tomoko was guiding, come in each week and provide a little bit of guidance or suggestion, answer some questions so they stayed on track, and then at the end come out with something like this was really amazing. And there were some bumps, getting IRB approval was probably the biggest one, but getting patients and staff scheduled and all that kind of stuff, but it worked out, and I think the fact that we ran a similar project again with this internal radiation for gynecologic cancers speaks to, I think that it was well received here and well received at our institution. I can give you a little other information. So this is available now online, but to download it, you have to fill out a brief survey. And so we've collected information. It's been downloaded about 200 times now, but we have people in South America translating into Spanish currently. I got a call from a major academic medical center back east that wants to use it in their clinic. It has to go through some bureaucratic hoops, but again, because it's not branded heavily for University of Chicago, it allowed it to disseminate very naturally. I also had residents that come and rotate with me who, when they see me use it, go, "Oh my gosh, I want that in my clinic." So one guy graduated, he practices in Indianapolis now and is using it there. Doctors are often set in their ways, probably. And so I don't expect this to suddenly change everybody in radiation oncology, but I think coming up with novel ways to educate patients using rigorous methods that we can provide an explanation for why it's designed the way it is, instead of saying, well, that's what me and my friends thought one day in a conference room. This is like, no, we spent 15 weeks with an entire team using design principles. It is more likely to be adopted. And I would hope in 20 years we'll see this kind of educational tool being used more broadly in medicine.
I'll just speak to that sort of added. Like one of the sort of challenges to using something like this, especially on the adult side, is that it's not taken seriously sometimes, right? That comics are for kids, and so you see a lot of comics in sort of pediatric education, right? There are comic books about various conditions, for the pediatric population, but you don't see this in the adult side, in part because the thought is that comics are for kids. And the other concern is, when you use something like this, and if somebody says, "Oh, that's just a comic," is it trivializing a serious situation, right? Radiation. You have a cancer diagnosis and you're receiving radiation. Like, why are you turning this into a comic, right? We should be treating this more seriously. Sort of critiques that comes up about using comics in patient education, that it may be perceived by patients as trivializing or sort of infantilizing an adult, to be like, "Oh, we're giving you this comic about your condition," like, but I'm not a kid. Why am I receiving this? And I'll be the first to say too that this doesn't work for everyone. Right? There are some that are not visual learners, so they don't gravitate towards this. And so this is not the sort of the be-all to end-all in terms of patient education, but I think it's sort of a significant contribution to how we think about patient education and moving beyond pamphlets with lots of words and more generic photos, like stock photos.
Doctors smiling with stethoscopes.
Yes. And holding clipboards, which none of us hold clipboards anymore, which I just don't understand.
Yeah, I lost my train of thought. Well, Jeremy, I'm curious what your thoughts are about using graphic narrative as a way to teach patients. Did you feel like it was trivializing? You can be honest. I'm not treating you anymore, so no. Can't do anything to you.
We have an appointment on Friday, so. I honestly think that it really helped me. With Northwestern, they gave me a big binder full of papers with like different sections to go through. Like if I was getting surgery one day, they'd have a paper there for that. And the only time I read it was when I had one surgery where they pulled they did a little biopsy, but they had to like open me up and pull it out, right? So there was like a surgery prep, and I had to find it. It took me like 20 minutes to find it, and then I had to look for the little section for it, and that binder was just terrible. But don't tell them I said that.
Be reported.
Not a plan.
Yeah.
But I don't think it was trivial in any way. I think it just made it simple enough that I'd want to read it, I don't know if that makes me sound like a kid or something like that, but
I've had many like 80-year-old grandmas who love this. So I'm not saying you're an 80-year-old grandma either. So I mentioned how I learned. I have this degree in medical education, but I realized everything could be applied to patient education. There's this interesting concept called the Yerkes-Dodson law or curve. This is a study from like 100 years ago where they took rats and would shock them at different levels, and they looked at how quickly they could get through mazes. So at really low level of shock or arousal, they call it, the rat doesn't move. At just the right amount of shock, it stimulates the rat to move, and they'll figure out the maze as quick as they can. But if you start to overstimulate them and shock them too much, the rat freezes up and can't process what's going on and figure out the maze. And so you see this optimal level of learning with arousal, and when they get too stressed or aroused, the rat can't learn. Well, that applies in education too. So if your learner is highly stressed and highly anxious, and you're trying to teach them with very complex methods, they're not going to learn. And so this applies in medical school lectures or grammar school, but I also really think it applies in patient education. So when a patient comes in, their doctor told them they should be scared about radiation treatment. They don't know anything about it. Their grandfather had treatment and his throat was burned. They're going to be really aroused and very stressed. And so you have to figure out a way to, number one, lower that stress level, but also teach them with it in a way that they can process. So if I go in and start using doctor speak and give you a big binder and you're really stressed, you're probably not going to be able to process it. So I think that's where I really think from a pedagogical standpoint, teaching my patients about what they're going to experience, this tool allows me to hit that curve in the right spot.
When we went to our first research, a site visit to your office, we were in the waiting room waiting for you to come out, and there was a gentleman in the waiting room, older gentleman, silver-haired. He was reading the newspaper, and I took a peek at what he was reading. He was reading the funnies. He was reading the comic pages, and I thought, well, this must be a good omen for us. I don't know if he was waiting to be treated himself or he was waiting for somebody else that he accompanied. But the fact that, that sort of validates the fact that everybody reads comics. We did very much so, though, during the interview. We were very aware of the language, and we did not use the word comics at all. We used graphic narratives, visual narratives, illustration, precisely for the fact that we did not want to trivialize in any way what the patients were going through. So that was a very conscious choice.
And I'll add to that when you do show this to patients compared to, if any of you have seen patient education materials, right? Like, there's something visually stimulating about these that makes patients want to engage with them. And in one of the pamphlets that I've a study that asked patients about that, right? Like did they find it visually stimulating and sort of engaging? And sort of the vast majority did. When we think about just handing them a sheet of paper with a bunch of words on it. And so, whether that's sort of the novelty in terms of patient education materials, or I think that's just sort of the comics medium and sort of the visual nature of these type of patient that too are also kind of novel to re-engaging with the material. That it is something that when you talk to patients with it, they take it home, they to engage with it, and I think that's sort of important for reinforcing what patients are going through and sort of reinforcing the information that they may have received in the clinic visit.
One quick thing is the Yerkes-Dodson curve works both ways, so I also tends to be more older men who will be kind of sitting there looking at the ceiling or looking out the window, and their wife is hanging on every word, and the patient themselves is completely disengaged. So I'm actually very conscious when I go in the room. We have a consult room with a circular table. The patient's dressed. There's no exam table. But I always sit just to the right of the patient because I'm right-handed. So when I'm writing and pointing on this, if they're on my right side, they can't see over my hand. So I'll actually have them move around the table if I have to so that I'm on the patient's right. And it'll engage, I find, usually more so these older men who otherwise would be staring out the window and waiting for me to finish blabbing at them. Suddenly there's pictures and, I'm telling them a story and here's what you're going to do. And they're like, oh, okay, I'll start paying attention. Maybe.
Shock.
Yeah, I just want to make sure that, so we've a little bit past the 1 hour mark, but we can continue the conversation. But I want to just take a moment and to thank everyone for coming. The panel is still here. We can still continue to answer questions, but I do want to give people the chance to.
Thank you, Jeremy, too.
Yeah. I cannot tell you how much designers here are incredibly happy to hear somebody use something that we.
I didn't even have to tase him to get him here.
Yeah.
definitely. Like Tomoko said, it was disarming. It caught me off guard. I felt like I was really engaged with the doctor. At times before surgeries and stuff, maybe a doctor would sit down with just a piece of paper with words and tell me, oh, here's where you can call, here's where you can see if you can eat beforehand, but nothing really to this level, you know. That's a good question. I really don't know. I like the paper form much better.
We have thought about, so I think for the one-on-one doctor-patient discussion, having the physical guide, I can't see doing this the way I do it with a tablet because I'm writing and drawing.
Exactly.
But we have discussed either making this into maybe an animated kind of whiteboard type video, or trying to digitize it in some way so that somebody could go back, but digitally, and kind of review what was discussed during the consultation online or on a mobile device.
And there is a lot of sort of discussion in sort of how the electronic computers kind of being.
Yeah, so I should have mentioned her earlier, but one of our residents at the university, her name's Ritu Arya, was integral to getting this off the ground. She helped write the IRB protocols and the initial funding for the pilot grant. She would have been here on this panel, but she's actually doing some rotation. She's in her last year of residency, so she's out of the state. But she and I have spent a lot of time kicking around ideas about what endpoints could we measure. The good news about radiotherapy, although it's bad news for our endpoints, measurement endpoints, is people tend to be very adherent, at least in the clinics. There are some clinics maybe serve very medically indigent populations that have adherence issues, but generally people come in for their treatments and will make it on time. I think that's why we were really interested more in anxiety level and the patient experience. You tell a patient verbally you're going to come in a week for a planning scan, but you don't mention they're going to get a catheter because they have prostate cancer, and you didn't specify whether or not they could take medications, and they go home and don't know, and they just know they're supposed to show up at 9 o'clock versus using this and saying you're going to have a catheter, you can take all your normal medications, other details. Does it reduce anxiety because they feel like they have more understanding and better information about what they're going to experience? So, some people could argue, from a cost standpoint, is that worth the effort or the time if we're still treating the patient? But I do think there's more to health outcomes than just did we cure the cancer or not, or did we treat the patient, right? Are they satisfied? Are they less anxious? You can treat somebody but send them a $100,000 bill, and they'll have horrible quality of life for a year while they're dealing with their insurance company. So there is more to measure, and so that's why our primary endpoint is going to be anxiety. We do have some knowledge endpoints. So secondary endpoints will be measuring knowledge about the treatment process with some questions. Will you experience this or that, or things that are touched on in here that maybe wouldn't be discussed otherwise. Yeah.
I have a question for Jeremy. So what specifically did this patient education tool accomplish for you that other educational tools you've probably been given couldn't accomplish?
It felt like it was really personal, if the doctor gave me, like I said before, just a piece of paper with a bunch of words on it, I felt like I wasn't really having that one-on-one connection with them that I had with this tool. Does that answer your question?
A little quick anecdote is I had a patient yesterday who I saw for a new consultation who coincidentally is a late middle-aged woman with a lung cancer in exactly the spot in this pamphlet who I said, I have to be honest, every patient that comes through my clinic gets this pamphlet, and her and her family started laughing and said, we thought you had one of these for everybody. Because I had just drawn on a diagram of the lung here where the tumor was, and then I started flipping through, and I said, oh, look, this is where your tumor is. But we chose a lung cancer because it's the most common malignancy in both genders. And you had to choose a right or a left lung. And so it's actually happened a few times because people have two lungs. There's a 50-50 chance it's going to be on the right side. Most people have two lungs.
I'd sort of add on to that, sort of another interesting sort of take on this to potentially do is to leave the face blank and then create stickers of the person, and so you could really sort of super personalize it with them. But then it's like, well, what are they smiling as they're doing this, or what should their face be? But we around and threw out these ideas about how to actually make it more personal, and can you somehow, if you did something digitally, could you create a picture in their picture, then becomes inserted everywhere to play around, but then too personal, right? Is it like, oh, that is me in the scanner? Yeah.
Yeah, I'll add really quick. One thing I didn't mention is we will also be surveying the doctors that participate in this prospective study about their experience. And just sitting here, I was thinking, there was some mention of the electronic medical record and how computers are coming in between the patient-doctor relationship. And I think from a doctor's standpoint, hearing you say that it was valuable and different because it was customized for you, it actually gives me the opportunity to demonstrate that I'm really paying attention to the patient and I am customizing, and this is really about them. It's not just a factory and they're being churned through. We have 20 other Hodgkin lymphomas. Next. This is you. This is where we're treating. And I almost wondered. I mean, hard to measure, but could this impact burnout in a favorable way? There's a big problem in medicine with burnout, physician burnout. And the EMR is often pointed at, there's other contributing factors. I find, for me, what prevents me getting burnt out is having interactions with patients and then having them tell me they appreciated what was explained or they feel comfortable now because I explained something to them in a way that was tangible and accessible. And this allows me to do that. So
I think the production of it, too, when you look at it and it's something different, we sort of did sort of an informal kind of survey of patients with another one of these, and it's like, does it show that we care, right? And so just this product itself, does it show that we care when you're not given just a binder of stuff or a folder with a bunch of crooked photocopy of a photocopy, right, in a patient education pamphlet, that this actually is like, oh, they went the distance, and they don't know the 700 hours that went into it, but it's unique and it's different and it's really trying to speak to me. And I think there is, is that something that could be measured, like this patient pamphlet shows that, my providers care or my institution cares.
I think it's actually a testament to how well this is designed that nobody realizes there's 700 hours that went into it. It's very seamless. It fits into my consultation very effortlessly, and in some ways it's good that people don't realize this is some huge production that went into designing this. It fits very naturally into the flow of the clinic and the discussion. Sorry.
Yeah, hi, I'm Ray. First of all, I just want to say this is a beautiful project, and it's effective, and I love it. I'm curious how you would imagine graphic narrative being applied to other relationships and systems. Like, I'm thinking like probation officers, financial aid counselors, you know, like agencies. Like, how would you imagine this to be a really useful tool outside of healthcare?
I think there's this growing trend in the world where a lot more burden is placed on the individual to learn about things, right? Like financial literacy, retirement choices, right? Even how to buy a house or what to do with your student loans. I mean, there's a lot of things that are systems-based that a lot of people have to go through, but they are individual experiences. And there's a lot of opacity in the process. So you don't know what's around the corner. You don't even know how many corners there are. And these are experiences that it's not like going to a restaurant that you want to repeat, right? What if you hit somebody with your car? You get summoned to court. There's all these sort of things that you would actually want to avoid, but yet systems are in place to handle them. I kind of casually call these oh shit moments, right? And so I think design is in the past, because it's been a commercial endeavor, has tried to sell you things or make you go to experiences like restaurants or movie theaters and make them a pleasurable experience for you. But I think there's a lot of experiences in the world that are not pleasurable and that we want to avoid, but yet we have to because life is messy, right? I think those are prime candidates for things like this, where there's a lot of opacity, there's a lot of expertise that's built into the system, where lay people don't have an inkling about, but yet when they're confronted with it, they have to deal with it, right? So I think there's a lot of legal, financial, any kind of continuing ed, retraining for people who are out of work. I mean, lots of things, right? Lots of social concerns. Prime targets for this kind of explanation.
What I would add to that when sort of thinking about graphic narrative and sort of comics as a medium is I think one thing that it can be sort of very, very useful. You can do multiple narratives, sort of layered, right? So for something where you do have to make a choice, right, you could show what those different choices are in sort of in parallel. And so different sort of treatments, just still using it, right? If you choose, surgery and chemo, this is what a narrative may look like. If you just choose surgery, this is what to expect. And so it's really useful and helpful, I think, not just complex, but areas where multiple narratives or multiple sort of outcomes are possible or multiple choices are needed, that you can show those in parallel. And one way to show how complex this problem may be, but also to simplify that complexity.
So I've gotten multiple hand signals to pause. But again, everyone, thank you so much for your time.
Thank you.
This has been really wonderful, and anybody here who is thinking about Institute of Design, this is really a place that allows us to do some really great collaborations like this. The panel is still here. Feel free to walk up and continue the conversation. Have some snacks, and thank you again, you guys.
Thank you very much for coming. Thanks, everybody.